Our next presentation is actually a combination presentation with Dr. Ginna Priola and Dr. Noor Zwayne. They are going to be talking about the management and approaches to bleeding dysfunction in adolescent females. Dr. Priola went to medical school at Eastern Virginia Medical School and then did residency at the University Hospital of Cleveland and fellowship at the University of North Carolina. She joined our team a few years ago and has been focused on immune-mediated bleeding disorders, as well as greatly involved with the educational residency program. Her colleague today, Dr. Zwayne, went to medical school at UTMB in Galveston. She then did residency at Banner University in Phoenix, and fellowship was at Sick Kids in Toronto. She then worked a while in Phoenix Children's before joining our group here in adolescent gynecology in 2021. So welcome, both of you.
All right. Thank you guys for allowing us to speak. Again, I do appreciate you guys giving up your Saturday morning to learn more about what we do on a day-to-day basis and how we can interact with you as general pediatricians. I am very blessed to work with Dr. Zwayne and her partner, Dr. Afri Gray, here at University of Texas Dell Medical School, and it's been really a pleasure to dive into this topic a little bit more and figure out how we can help the community and help the young girls out there with heavy menstrual bleeding to be able to get the best care possible. So we'll get started. Dr. Zwayne has no disclosures. I also have no disclosures. So we're gonna get straight to the objectives. So the purpose of this talk is to review abnormal uterine bleeding. I'm gonna tell you, I actually got educated during the process of putting this talk together from Dr. Zwayne about the new terminology that's being used. There's some terminology I think we all learned in med school that has now been kind of replaced with some more appropriate terms to describe what the condition is. We're gonna also discuss the definition of heavy menstrual bleeding in adolescents. We're gonna discuss the etiology of heavy menstrual bleeding in adolescents, discuss pediatric adolescent gynecology's role in the diagnosis and management, as well as the pediatric hematologist's role. And then we're gonna discuss commonly used treatment modalities and general resources for the general pediatrician. So I'm gonna hand it over.
Okay, is it this button? Okay.
Yeah, boom.
Hi, everyone. Lovely to see you all on this Saturday morning. Okay, so one thing I like to review is the terminology. So I like to think of abnormal uterine bleeding as an umbrella term. And it's an umbrella term that's referring to menstrual flow outside of the normal duration, volume, regularity, or frequency. And that's according to the American College of OBGYNs. It's pretty common. It can impact about a third of women in general. And in 2011, FIGO came up with a new classification system to better delineate this abnormal uterine bleeding so we could better understand what each patient was experiencing. Okay, so I don't know if you guys have seen this, but this is called the Palm-Cohen classification system of abnormal uterine bleeding. And it's referring to the different reasons for abnormal uterine bleeding. So on the left-hand side, it's a lot of the structural issues that can happen, such as a polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. These are very common in adult patients. We don't really see this much in adolescents. It's possible though, but less so. And then the other reasons would be coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. The most common reason we see, and we're gonna delve into this a bit more, is ovulatory dysfunction and then coagulopathy in this particular patient population. Okay, so I thought this was a really helpful way to better delineate what abnormal uterine bleeding is versus normal bleeding. So as you can see, the grayed areas are what's considered abnormal, and you can see the different parameters. So we've moved away from terms such as menorrhagia, oligomenorrhea, dysfunctional uterine bleeding, although there's still ICD-10 codes that describe that. So sometimes we do have to put those in our charts. But the proper terminology is according to the different parameters. So you can see with frequency, we still use the term amenorrhea, and then we use either infrequent or frequent menses for those abnormalities. The duration also is classified here as normal or prolonged. Regularity, so regular or irregular. So often I'll say irregular bleeding. Flow volume, light, normal, heavy. And then intermenstrual bleeding is not very common in adolescents, but you may see this. Adolescents are notoriously poor historians, so it may be a little bit difficult to get all these proper parameters identified in teenagers. And then unscheduled bleeding is common, especially if they're on hormonal medication that may cause breakthrough bleeding. Okay, so what are the causes of abnormal uterine bleeding? The most common cause across the board is going to be immaturity of the HPO axis. And I often tell patients and parents that it can take for some patients up to 5 years for periods to regulate. It varies from person to person, but generally speaking, I want to give them at least 3 years to regulate their menses before I consider other options. Of course, it's on a case-by-case basis. Certain patients may be more prone to certain causes of abnormal uterine bleeding. Pregnancy, definitely, I don't want to be the gynecologist that misses that. That would be poor form. And so all my patients get a pregnancy test. And then hyperandrogenism. If you notice a patient has significant acne, hirsutism, you may want to be considering an abnormal uterine bleeding. Other causes such as PCOS or late onset CAH. I could do an entire talk on PCOS in adolescents. It's very different than it is in adults. I'm happy to discuss that with anyone later if they're interested. I have a special interest in CAH personally, and so these are things that I'm also thinking about as well. Thyroid disease can notoriously cause abnormal uterine bleeding. Primary ovarian insufficiency, so ovarian dysfunction can certainly cause abnormal uterine bleeding, particularly amenorrhea or abnormal uterine bleeding in general. STIs can cause abnormal uterine bleeding. Teenagers may be reluctant to discuss this. All my patients get a HEDS assessment because that's an important part of my role as a gynecologist, which I'll delve into a little bit more. And so being able to assess whether or not that may be a cause is very important. And also being able to educate patients about STIs. Can't tell you how many teenagers tell me, I didn't know I needed to use a condom for oral sex. Why would I need to do that? And so, sorry, I talk about sex a lot as a gynecologist. Sorry. But certainly that's obviously you guys know better than I do the importance of educating and providing evidence-based education for your patients. Medication, so certain medications may lead to amenorrhea. One that comes to mind that I often see is risperidone. So I often will review all the medications that may be causing this. And then obviously underlying hemostatic defects as well, which Dr. Priola will go into. Okay, so what is the definition of heavy menstrual bleeding? So this is excessive menstrual blood flow that interferes with the physical, emotional, social, material quality of life and can occur alone or with other symptoms such as dysmenorrhea, for example. This is pretty common. It impacts up to 40% of teenagers, and it can be associated with menses greater than 7 days. Blood loss exceeding 80 mLs per period. Obviously, I'm not expecting any teenager to weigh their pads or tampon, but a red flag for me as a gynecologist would be, hey, I have to change my pad or tampon every hour continuously. Or if they're having to use double protection continuously or flooding their sheets or often having to change their clothing, that's a red flag.
So this is just a quick chart that was in a very comprehensive article authored by Sarah O'Brien, who is a pediatric hematologist at Columbus Children's, who really breaks down those signs and symptoms of heavy menstrual bleeding. And I think what's really important from our perspective is there the presence of anemia? And if there is the presence of anemia, then that really does push us more into a concern for an underlying bleeding disorder. So what are the most common underlying bleeding disorders? Von Willebrand's is by far the most common underlying bleeding disorder that we're going to see. We also can see platelet function defects. That's the second most common. So there are certain disorders that are associated with that. You can have clotting factor deficiencies. Dr. Mitchell mentioned a lot of these particular disorders. We're not going to go into super depth here. You can also have fibrinolytic disorders. So you have a dysfunction in how the body breaks down a clot. There could be a bleeding tendency due to a generalized joint hypermobility syndrome, which is something that a lot of times we don't think about as hematologists, but we're starting to really realize that that really can be impactful when it comes to isolated bleeding disorders such as menorrhagia, or even simply epistaxis or generalized bruising, which we do get on occasion a referral from general pediatricians just for the increased bruising without a change in the platelet count or any kind of abnormal coags. And so that's something that's always on the list for us to think about. And then immune thrombocytopenia, or ITP, is certainly something that can present as menorrhagia in or heavy menstrual bleeding, my apologies, as a primary symptom in the adolescent population. And I've had this happen to me quite a few times, that when you then go and check the CBC, they have a very, very profoundly low hemoglobin or platelet count. So the hypomobility syndrome, just a quick touch on that. They should be considered with significant bleeding dyscrasias without a clear diagnosable condition. Like I said, normal platelet counts, normal coags. It's much more common in females, and the bleeding tendencies is often secondary to an increase in the capillary fragility, as well as alterations in that collagen protein involvement in that platelet function. Most of our hypermobility syndromes are associated with deficits in the collagen production and function. And collagen is absolutely necessary to attach with our platelets and attach with our von Willebrand to make that proper clot. Changes in the interactions between the exposed collagen in the endothelial walls and the platelet receptors and von Willebrand. So a physical exam is definitely necessary. So looking at some of those criteria that put them into a higher concern range for a hypermobility syndrome is certainly helpful. So I'm going to give this back to Dr. Zwayne, and she's going to talk about the role of the gynecologist.
Okay, so what is our role as gynecologists in the management of heavy menstrual bleeding or identification? And so we'll often perform the clinical laboratory evaluation of heavy menstrual bleeding on the basis degree of clinical suspicion. So not everyone who comes in to see us has those red flags that we may be concerned about. But I think it's important on a case-by-case basis to ascertain what that specific patient's needs are. So sometimes even if a patient does not have a low hemoglobin or platelet count or hematocrit, if the heavy menstrual bleeding is impacting their quality of life, that warrants treatment. Like I said, the diagnosis of heavy menstrual bleeding impacts quality of life. And then identifying and managing any concomitant conditions. Speaking of hypermobility syndrome, I saw 5 patients in the last 2 weeks with Ehlers-Danlos and significant heavy menstrual bleeding, which was a bit odd in 2 weeks to see 5 patients with that. And so the importance of managing concomitant conditions, what medications they're taking, what they may be at risk for, if not anemia now, maybe in the future, and identifying that is critical. And then providing first management with available hormonal therapies to better control menses, which we'll delve into a bit more. So with regards to our history taking, obviously we're reviewing menarche, the menstrual history, frequency, changes in patterns, sexual history, as I stated earlier, is very important, pregnancy history as well, past medical history, any chronic illnesses or medications they're taking, prescription as well as over-the-counter. There's been a lot of push lately for more natural medications, and so there's a lot of estrogenic medications that I have patients taking. So I've definitely had to delve into more education for myself about that may impact bleeding parameters. Bleeding symptoms, are they experiencing anemia? Are they fatigued? Are they having trouble sleeping? Bowel changes, dysmenorrhea, is it impacting their ability to go to school? And then family history. One question I often ask is, did mom have any postpartum hemorrhages? Anyone in the family have a history of heavy periods, eliciting whether or not there's some sort of genetic component to this. And then social issues. So the year that COVID came was the year of the irregular period. I mean, everyone was missing a period. I swear to God, it was nuts. And so the impact of stress can be quite significant. I mean, we often say that the menstrual cycle is a barometer, is a vital sign. And I think that's certainly true. If COVID taught us many things. That was one thing it really taught me. So stressors, physical or emotional, whether or not they've been diagnosed with something, whether or not they're experiencing bullying, that certainly can impact things. Exercise. Are we looking at a runner or a dancer that dances 20 hours a week? Are we looking at someone who may have some sort of eating disorder or a restrictive, especially restrictive eating disorder? All of these can impact the menstrual cycle. So when they come and see me, it really is a comprehensive visit. We go through a lot. They're long visits. We go through a lot of these things that I have to, as a gynecologist, elicit to figure out what is going on or to have a better understanding of the patient that's sitting in front of me. Physical exam, so obviously I'm reviewing vital signs, growth parameters, obesity, underweight, stature, skin and hair. I will often do a thyroid exam, although I'm sure you guys do that way better than I do. I do an abdominal exam. Not every patient who comes and sees me gets a breast or genital exam. It is largely dependent on the situation. Again, we do not perform pelvic exams routinely until age 21 unless there is a specific issue going on. So in this topic, I would say if I'm concerned about some sort of congenital anomaly, I may perform a external genital exam in that scenario. A breast exam would be warranted if a patient comes in with amenorrhea or very irregular periods and has nipple discharge. I may perform a breast exam, but it's, again, not routinely done. And then, again, pregnancy test. Don't want to be the gynecologist that misses that. And then FSH tells me whether or not the ovaries are functioning properly. And so I will often order that, and estradiol levels, TSH, T4 as well. If I'm concerned about hyperandrogenism, I may order a testosterone-free in total, a 17-OHP for late onset CAH, DHEAS to look at the adrenals, and then CBC iron profile, and then based on the history, possible von Willebrand testing, and then obviously assessing platelet levels as discussed, and then STI screening if warranted.
So in tandem, you'll actually see some repeats in how we look at these referrals as well. Our role is to perform the clinical and laboratory evaluation of heavy menstrual bleeding on the basis of degree of clinical suspicion. We'll talk a little bit more about what would fall into that range of clinical suspicion for a bleeding disorder. Identify and manage any concomitant iron deficiency or iron deficiency anemia, which is quite common in this population, and provide input to the referring provider regarding the management of heavy menstrual bleeding, particularly in patients that have identified hemostatic defects. So our history is very similar. We're going to get the menstrual bleeding history. We definitely are going to dive a little bit into what their background history is. Do they have a history of bloody noses? Do they have a history of gingival bleeding with teeth brushing? Are they an easy bruiser? Have they ever had blood in their urine or stool? We're going to look at their procedural bleeding history. And a lot of our kids have never had surgery before, but certain things that you might not think about, did they have excessive bleeding with primary tooth shedding? Is this a kid that lost a tooth in daycare and mom got a call, oh my gosh, come get your kid, they're bleeding and they just lost a tooth. Tooth extraction, a lot of our kids get braces and they have a tooth that's extracted. It's very important for us to know whether or not there's any excessive bleeding that was associated with that tooth extraction. And then any other surgical procedures. Oftentimes, the most common surgical procedure we're going to hear about in our population is a prior TNA. And I will tell you, that is a really good procedure to tell us whether or not they have a hemostatic defect. Because it's mucosal, because it's mainly using that primary von Willebrand and platelet activation to provide hemostasis. If there's any deficits in there, they often will show that with either prolonged bleeding during the procedure or postoperative bleeding between 5 to 7 days after the procedure happened. Family history, just like Dr. Zwayne asked about family members with peripartal hemorrhage, heavy menstrual bleeding, and siblings, mothers, aunts, grandmothers on both sides is extremely important to us, as well as a medication review. We know that nonsteroidals and aspirin do affect platelet activity. And so if they do notice that there is increased bleeding along with taking any of those medications, that's also going to prompt us to be a little bit worried that there might be an underlying bleeding disorder, because you shouldn't necessarily bleed just because you took Motrin. And review of symptoms is really kind of trying to flesh out that underlying iron deficiency. So looking for symptoms like fatigue, malaise, decreased endurance, shortness of breath, headache, dizziness, and pre-syncopal episodes or actual syncopal episodes. Dietary history is definitely important. I don't know how many times I see our teenage population and they're like, I skip breakfast, I skip lunch, I maybe maybe eat dinner with my family. And so in my world, that definitely makes me concerned about how much iron are they getting in their diet. And if they're having heavy menstrual bleeding and they're not intaking a lot of iron through their diet, then we're gonna run into an iron deficiency really fast. So these are two things I just wanted to kind of mention to you. There is a bleeding score. It's a bleeding assessment tool. And this was actually part of the International Society of Thrombosis and Hemostasis. And there are definitely markers that can be used in both children and adult females and males based on their bleeding score. Unfortunately, the adolescent female population doesn't have good scoring because unfortunately their scores are kind of somewhere in between, because a lot of the things that we assess in the adult females, our adolescent females haven't actually encountered yet. And this is another one, is the Philips Brief screening tool. Again, I'm not gonna push on the link because I don't want to break the presentation again. But this is actually used to identify those at increased risk of underlying bleeding disorder. It's a sensitive tool, especially in combination with another assessment tool called the Pediatric Bleeding Assessment Chart. There does exist some age differences in that adolescent population. So as you can see, it sounds like there really needs to be a lot more focus on our poor adolescent females to better assess where they lie in these assessments of underlying bleeding disorders. So the sensitivity is really good for the adult females, but it does drop to about 62% in our adolescent population. Our physical exam is not quite as robust. I mean, certainly we're gonna do a routine physical exam, but we're gonna look for any evidence of anemia in the skin exam, such as pallor, excessive bruising, or petechiae. That would give us an indication that maybe there's some platelet dysfunction happening, and then looking for those joint hypermobility signs. So I'm sorry, that is actually the pediatric hematology lab evaluation is going to include a CBC and reticulocyte count. As you heard from Dr. Chang, reticulocyte count give us a better understanding of where things are in the evaluation of a potential anemia. Typically, if our kids are having significant menstrual bleeding and their iron stores are still relatively replete, we will see an increased reticulocyte count. However, as that iron deficiency continues, that reticulocyte count will start to fall because they no longer have what I call the building blocks to make those red blood cells. And so that reticulocyte count will change with time. Ferritin, I will tell you, is my most favorite evaluation of iron deficiency. Our iron studies can be very heavily influenced by various different factors. So I don't know if anybody has ever taken an iron study before and found out they had an iron level of 325. That's probably because they actually took their iron that morning before you actually drew the exam or drew the study. So ferritin is much more direct as far as the iron deficiency. And basically what we're saying is if it's less than 5, that is definitely signs of a severe iron deficiency, and most places are actually saying ferritin's less than 20 are indicative of an iron deficiency anemia. I just went to a a big international conference this winter, and there's actually debate of should that number even be higher? Should it be 30? Should it be 50? So I think there's more to come on that. The von Willebrand panel and the platelet function assay are very key to how we diagnose those underlying bleeding deficiencies. So I will say we do prefer to do them here if we can, simply because von Willebrand itself is a very sensitive lab, and I'll get to that in the next slide. And the fact that stress, inflammation, illness will actually increase von Willebrand results, and they can actually be shown to be quite elevated in a child that presents with severe anemia secondary to having menstrual bleeding. So a lot of times what happens is they present to the ER, they get those baseline testing, and then we get a call because their factor 8 is 250. It's probably because they're stressed. It's probably because their body is trying to compensate for such a severe anemia. And so we really do prefer to wait on those until we're able to get that menstrual bleeding under control. Same thing, a platelet function assay can be prolonged in a more iatrogenic way if there is a hemoglobin less than 10. So we'd like to make sure that anemia is corrected before sending those tests. And just for you guys to know, platelet function assays can only be run here at Dell. Unfortunately, CPL and some of our labs in the community don't actually run those tests. And then I'll go ahead and hand this back over to Dr. Zwayne as far as how do we treat this?
Okay, so I think one important thing is to figure out whether or not this is an acute bleed or a chronic bleed. And is the patient at risk, or does the patient need to be hospitalized? Certainly, if this is a patient that needs to be hospitalized or admitted, the treatment is going to be very different than it would be in the outpatient setting. And so typically, most patients receive an oral, if they are in the outpatient setting, an oral estrogen-containing or progestin-only hormone. And we do have algorithms here at Dell Children's regarding how to manage these patients, which I think is really important. In the outpatient setting, I'm going to go over all the different medications that I offer, but typically to stop an acute bleed, I typically will do an OCP taper, so a combined hormonal contraceptive taper. And I can delve more into that a little bit more. One thing I always am that's very important is to, and I drill this into the residents, does the patient have contraindications to estrogen? Something we may not be thinking about. So contraindications that I have to have documented would be migraine with aura. Is there a family history or personal history of DVT-PE? In that situation, you have to avoid estrogen until you figure out a little bit more. And so in that scenario, I may provide a progesterone-only option. My preference would be a combined hormonal contraceptive. That's what's going to stop the bleed faster, but if not, then we may have to resort to a progestin-only. IV medication is used for patients that are more unstable and are admitted, and typically that's an IV estrogen that we use, and with that, we'll cease the bleeding within 24 to 48 hours at most, and then we typically transition to PO medication. Antifibrinolytics.
So they are used to augment hormonal therapy. We try not to do a bunch of overlap in that, just because there is a slight increased risk in thrombosis when they're put on top of each other, especially if it's an estrogen-containing agent. However, it has been shown to be effective. There was a study of about 1,100 admissions for heavy menstrual bleedings in children's hospitals in the US that showed 50% of them received monotherapy with a hormonal therapy, and the most common agent was a COC. And then 30% received 2 forms of hormonal therapy, and then it was only about 8% that received both a hormonal and antifibrinolytic therapy, and only 1% actually received antifibrinolytic therapy alone. And as previously discussed, it's really important to assess that element of iron deficiency, and close follow-up is needed from both a pediatric adolescent gynecology perspective as well as a hematology perspective, especially in those kids that present to the hospital.
So treatment options this is hormonal medication. So the non-hormonal medication would be an antifibrinolytic such as TXA. Can be hard for patients to take that because it's prescribed 3 times a day. Most patients don't even take 1 pill a day. And so that can be challenging, and unfortunately, insurance does not always cover it. So often we end up doing hormonal medication. I offer all my patients every option available, and we talk about the risks and benefits of each, and then they decide with the family what they would like to do. So combined hormonal contraceptives are the most commonly used in our patient population. And in adolescents, I prefer to use monophasic medications. And if you don't know what that means if you've ever seen a birth control pack, usually it comes in 4 rows. So the first 3 rows are going to be hormonal medication. The final row is the placebo week. And in monophasic birth control pills, every pill is the same amount of hormone. In triphasic, every row is going to be a little bit different. Do not use that in an adolescent. Adolescents need, especially heavy menstrual bleeders, higher estrogen doses, so please do not prescribe a low-dose pill that parents will ask you for. They need more estrogen to stabilize the lining of their uterus, and they need that consistent estrogen. Half the time, patients may not remember to take a pill every day, and so if you're already giving them a lower-dose pill or a triphasic pill, then it's going to be even harder to control that bleeding. Oh, sorry. Oh, I'm out of okay, sorry. Okay, we also have a vaginal ring, a patch. Everyone, please encourage the levonorgestrel IUD, especially for patients with heavy menstrual bleeding. It is the best option. It is approved by the FDA for treatment for heavy menstrual bleeding. Depo-Provera is an option, progesterone-only pills. I don't love in teenagers, but if you have to, you have to.
All right, so for the sake of time, we're going to go ahead and end here, but there are additional resources at the end of this slide. And we are always available to you. So please don't hesitate to give our office a call or the Pediatric Adolescent Gynecology office a call if you have questions, concerns, or want to refer a patient to either one of us. So thank you so much.
Thanks, bye.